Good afternoon. For those that don't know me, my name is Dan Geo, and actually serve as director of the Leukemia Lymphoma Program here at Children's National for the last 10+ years. And on behalf of the Center for Cancer and Blood Disorders, I'd like to welcome you to our annual Mental Lecture. It is a very special day for us to honor and celebrate the Toll family for their commitment over 3 decades to us here at Children's and to increase our knowledge in the field of pediatric bioethics. I do want to spend a moment I'm talking about Amanda. Approximately 30 years ago, at the age of 3, Amanda was diagnosed with the most common childhood cancer, the acute lymphoblastic leukemia, and she was under the care of my superb mentor, Dr. Gregory Reenan. Unfortunately, after attaining a remission state, she relapsed and we went out to the West Coast for a bone marrow transplant. But after exhausting all of those treatments, she passed, and at the age of 6. However, she continues to live in our hearts here, thanks to the Toll family. For the past 30 years, her vibrancy and energy to continue to live in our institution through the incredible generosity of the Toll family. Through their endowment, the Amanda Toll Educational Fund has provided support for our Grand Round lectures given by world-renowned experts, as well as providing other educational benefits for our physicians and nurses. Thank you to our dear Toll family. Now it's my great pleasure to introduce this year's lecturer, Dr. Eric Kodish. Dr. Kodish is a professor of pediatrics, oncology, and bioethics at the Lerner College of Medicine of Case Western Reserve University. After fellowships at the University of Chicago in both pediatric hematology oncology and medical ethics, he joined the staff at Rainbow Babies and Children's Hospital, where he was the founding director of the Rainbow Center for Pediatric Ethics. Currently, he serves as program director for the Pediatric Hematology Oncology Fellowship Program at the Cleveland Clinic. His areas of expertise are quite broad, and they include childhood cancer, blood diseases and disorders, pediatric ethics, end-of-life issues, informed consent, and research ethics. We actually initially met through our collaboration on a multi-site study on informed consent in pediatric childhood leukemia, and I learned so much from Eric. Dr. Eric Kodish has served as chair of the Bioethics Committee for the Children's Oncology Group. He's been a member of the Bioethics of the American Academy of Pediatrics and a member of the Pediatric Oncology and Pediatric Ethics Subcommittee at the Food and Drug Administration, just to name a few. He's authored numerous publications in peer-reviewed journals such as JAMA, Journal of Clinical Oncology, Cancer, American Journal of Ethics, Pediatrics, and the New England Journal of Medicine. So now it is my distinct pleasure to introduce you to my dear colleague, internationally recognized expert in bioethics, Dr. Kodish. The title of his talk today is Ethics and Research with Children, the Cancer Example. Thank you for coming.
Good afternoon. I would like to begin with gratitude, as my yoga teacher says, and end with gratitude. I'm just very, very grateful to be here, to have had the opportunity to meet Randy and Steve last night and have a really lovely dinner with you, and to your gracious hospitality here to see old friends and make new friends. And I'm looking forward to sharing some thoughts with you about research involving children and cancer specifically, hopefully a little bit generalizable to more broadly research involving children as well. I do have a disclosure. I get royalties from Oxford University Press for sales of our book, which I will mention. I don't recommend doing a book on the ethics of pediatric research if your goal is to make money. So let's start with a case. I think a lot of good ethics teaching starts with cases. There's a new drug. I hope you can see this okay. I usually like it when the sun is out, but it's good, I think, that the sun has gone behind a cloud. And, a new drug that targets a molecular trigger for malignant cell transformation is being studied in children with terminal cancer. I have been taking care of Abby, a 12-year-old with metastatic osteosarcoma, for about 18 months. She's dying. She's eligible for the drug study, but it holds only the most remote prospect of helping her. At the same time, the drug might be risky and it could accelerate her death. Without the participation of children like Abby, knowledge about this new drug and others like it will never be obtained, and we won't be able to discover better treatments for childhood cancer. Abby looks at me and asks whether I think she should be in the study. How should I answer her question? Where do I begin to analyze the moral issues that emanate from her story, and how do I balance rational and emotional components of my response, the head and the heart? How do those go together? Do I owe it to all children who will get cancer in the next several decades to say, yes, you should be in the study, Abby, so that future children will benefit? Or should I protect her from further suffering and say, no, I don't think you should be in the study? Perhaps saying we should go toward hospice or palliative care. By asking the question, is Abby looking to me for hope, or is she seeking my permission to quit fighting? And I don't know how to best respond to Abby. So what did I do? I decided to write a book about the ethics of research with children to help me and I think others around the country work through some of these challenging issues around research with very, very sick children. And this is a photo of the book. This is the second edition of the book now. And it's a case-based book, so every chapter involves a different case involving the ethics of research with children and ends with some questions for discussion. In the big picture, this is how I think about research ethics with children. A triangle geometry with the child at the top of the triangle, but very important stakeholders with parents and investigators who are doing research. And we need to consider all three of these angles when we're thinking about pediatric research ethics. And there are three compelling narratives that I wanted to put here at the beginning. The first one is that children are overprotected, and there are economic incentives that are aligned against the development of new drugs for childhood cancer. After all, it's a rare disease, thank God. There aren't many children with cancer compared to adult cancer, certainly, and drug companies do not stand to make a whole lot of money developing drugs for childhood cancer. The second narrative is that children are vulnerable to risky decisions made on their behalf by desperate parents and doctors. Sometimes we doctors are desperate too, who can't accept the fact that medicine has reached its limit, that a child is overmastered by disease, and we can't really do anything to treat or cure the disease. Or potentially that parents are simply misinformed by the internet. Sorry to say, sometimes the internet has inaccurate information. A third narrative that I think is compelling is that access to drugs that have been proven safe, but not necessarily effective, is a constitutional right. And we saw the Abigail Alliance case and now a bunch of right to try laws in a variety of states that are saying efficacy is nice, but it's not necessary, and patients should have access to any sort of medication if they're desperate. So those narratives, I think, help to set the framework a little bit for the conversation, and I hope we will have a conversation. I'm going to try to go through my slides fairly quickly so that we can talk at the end. But I want to begin by some careful analysis of language. The words that we use not only express what we feel, but I think they redound back to our brains and affect how we think. And I think that's really important when we think about research ethics. Let me tell you what I mean. When I was in my training in the 80s, early 80s, certainly we needed to protect subjects from research risk. That was a really critical issue. We had had a legacy of Tuskegee, of terrible experiments done by the Nazis, and it was all about protection. Along came the AIDS epidemic in the 80s and the breast cancer advocacy movement in the 90s and many other patient-centered movements that were demanding access to research for participants. And there was a lot of promise, and still is a lot of promise, of science, and a need for us as a community of doctors and investigators to separate the hype from the hope. So, what is research? It is a class of activities designed to develop or contribute to generalizable knowledge. What is practice? It's a class of activities designed solely, and I want to emphasize the word solely here, to enhance the well-being of an individual patient or client. That word solely means that if there is any element of research involved, it gets categorized as something that needs to be looked at for protection of human subjects. So in a very simple world, it would be like this. Doctors care for patients, and researchers study subjects or participants. As you all know, the world is not that simple. And I'll just focus for a second here on the difference between subjects and participants. Anybody in the audience doing research involving children now? Raise your hand. Good, right? Are the individuals who you're recruiting, and the word recruit is an interesting word too, are they subjects or participants when you approach them with an informed consent discussion? Or are they patients? Anyone have any thoughts? Potentially all three. Okay. Yeah, I mean, the way I think about it, if it's a very young child, it's a subject. If it's an older child who may be capable of assent, it's a participant. That sounds a little bit more active. And absolutely patients, right? If they have an illness and we're caring for them, looking after them, there's overlap. And I'll talk in a minute now about that overlap. Thank you for not being shy. The Belmont Report says, research and practice may be carried out together when research is designed to evaluate the safety and efficacy of a new therapy. This is my favorite line. This need not cause any confusion. When you see that in a text, it's a marker that there is going to be some confusion, right? This need not cause any confusion regarding whether the activity requires review. This means IRB review or not. The general rule, if there's any element of research in an activity, it should undergo review for the protection of human subjects. Again, protecting subjects from risk is the theme. The Helsinki Code, which is another code of research ethics, had a different gloss that I think is also really important. Unfortunately, in my view, they have removed it. So that's why I put past in parentheses here. This is no longer part of the Helsinki Code. They've changed it. But I think it was very wise. It said in the field of medical research, a fundamental distinction must be recognized between medical research in which the aim is essentially diagnostic or therapeutic for a patient, and medical research, the essential object of which is purely scientific without implying direct diagnostic or therapeutic value to the person subjected to the research. So quite simply put, if you align medical care over here, non-therapeutic research over here, is my arrow picking up there? Okay, great. And research with the prospect of clinical benefit, or what we call in pediatric research ethics, PODB, the prospect of direct benefit. Belmont is drawing the line here. It says medical care is this stuff, and everything else is research, whether it's non-therapeutic or has potential benefit. Helsinki drew the line here. They changed, but they used to say non-therapeutic research needs pretty tight regulation, but if you're doing this kind of research, it needs a little bit less regulation. We should think of clinical research, in other words, closer to medical care. And I'm not sure why Helsinki backed away from that, but there certainly is more harmonization now between the European view and the American view. The current version of Helsinki does have some very helpful things that are still in place, and I want to underscore. The primary purpose is to generate knowledge. This goal can never take precedence over the rights and interests of individual research subjects. I bemoan the fact that we don't have any statement in the American regulatory framework as clear and direct as that. I think we should. If I was king of the world. Helsinki also says physicians, many of you, who combine research with medical care should involve their patients in research only to the extent that this is justified by its potential value for the patient, and if the doc has good reason to believe that participation will not adversely affect the health or welfare of the research subjects. So we have in this country the Belmont Report, which I quoted from earlier, and it has three core sort of philosophical commitments. One is respect for persons, one is beneficence, and one is justice. And I want to spend a couple minutes on that before we get into some of the cancer stuff. Respect for persons, Belmont tells us there are two ethical convictions that underlie that. One is individuals should be treated as autonomous agents. That's the one that gets all the attention. As a pediatric ethics guy, that doesn't do me a lot of good, right? What does me a lot of good is the second one, and people forget that. Persons with diminished autonomy are entitled to protection. And that is the difference between respect for autonomy, which you hear people in bioethics drone on about sometimes, in my view, and respect for persons, which I think is a much better way to think about medical ethics broadly and research ethics. So those are sort of high-level values, but how do we operationalize Belmont? And quite simply, I think we do informed consent well if we're going to take respect for persons seriously, and I'll say more about that in a couple of minutes. We do risk-benefit assessment well if we're serious about beneficence, and we pay attention to justice in participant selection, in making sure that populations are not understudied, but they're not overstudied, that if we're going to a lower middle income country to do research, that we assure ourselves, and if the IRB not approve something unless there's a plan of sustainability in that country, that we're not being exploitative. Those are all ideas around justice. I won't spend a lot of time on that today, but important to be said. So let's drill down now to pediatric research ethics. What's the difference between informed consent and parental permission? As Dr. Angiolillo said, our study was a study of informed consent, but it was actually misnamed. It was more of a study of parental permission and assent. The American Academy of Pediatrics says your responsibilities as a pediatrician to your patient exist independent of parental desires or proxy. So in my view, this isn't the AAP, but I think most people agree autonomous authorization of adults for decisions related to themselves is more robust ethically than parental permission of parents on behalf of children. Pediatrics is complicated, at least in older children, because we have this notion of assent. So the combination of parental permission, one parent, both parents, three parents, depending on how many parents are in the situation, and the assent of a 14-year-old child, let's say, that, in my mind, when it works, might be greater than the sum of its parts. If it's done well and there's alignment, so to speak, of the older child with his or her parents, that's great. Sometimes there are discordant opinions, and those need to be navigated. Parental permission, as I said, I think is not the moral equivalent of informed consent because children are not the property of their parents. And permission from parents can be different in the clinical context from the research context. So informed consent, even just like for an individual adult who has decision-making capacity, requires competence before. It's a prerequisite, and then a process of disclosure, understanding, and voluntariness. And the data that I will show you from the studies that we've done really looks at disclosure and understanding carefully, and the connection between that. In other words, what researchers say and what parents understand when it comes to consent, parental permission for children being involved in cancer research. Assent in the clinical realm is a little different than assent in the research realm, and I think this is worth spending a minute on as well. There's a sort of parallelism of assent in the clinical definition to what I just showed you with informed consent for older patients. A child should be aware of the nature of his or her condition. They should know what to expect with tests or treatments. The clinician needs to assess understanding, whether the older child does understand and whether they're under any undue pressure to accept. And then I think a good pediatrician should solicit an expression of willingness from an older child to accept the proposed test or treatment. At least in American culture, Dr. Dome and I were talking last night about some other cultures where that might not make sense, and we could talk about those cases. But in general, I think this is the right approach. And the Committee on Bioethics of the American Academy says no one should solicit a patient's views without intending to weigh them seriously. In situations in which the patient will have to receive medical care despite his or her objection, the patient should be told that fact and not deceived. There's this risk that assent can sort of become a charade and be hypocritical. So the AAP deals with that, I think, in this very nice comment. Research is a little different because it's supererogatory. It's an option that people can have. And the regulations require a child's affirmative agreement to participate in research. Mere failure to object should not, absent affirmative agreement, be construed as assent. So as Paul Simon says, furthermore, I hope my feelings won't be lost or misconstrued, right? Don't misconstrue a child's silence for assent when it comes to research. So it's a difference that I think it's important to point out. Clearly, the older the better for both treatment and research when it comes to assent. We know that, as I said, research should be optional. There are rare cases where a child can't get access to a treatment unless it's in the research context, and those are thorny but interesting, certainly. And maybe for research, we should have veto power for all three. I mentioned the Nuremberg, or the Nazi experiments, which led to the Nuremberg trials earlier. And the first point of the Nuremberg Code is that the voluntary consent of the human subject is absolutely essential. And then in small print, it says this means the person involved should have legal capacity to give consent. So if we're black letter intensely focused on Nuremberg, we can't do research involving children. It's a non-starter. And if that's the case, then we have to wring our hands and say future children are going to suffer. We can't, because a 5-year-old can't give consent to being in a study. And Nuremberg says unless you have the ability to do consent, you can't have a child in a study. So I think there's been a societal consensus that we must do pediatric research. How do we do that in an ethically sensitive way? And how do we comply with the spirit of the Nuremberg Code without the black letter? So that's, I think, what we do with these three things. We use parents as surrogates. We get their permission for research. We involve children if they're capable of being involved, and that's what we call assent to research. And then I think most importantly, we have a mechanism of societal protection, which is sort of embodied in the IRB. And if we do that, I think it's okay, and even actually better than okay, really ethically important to do research involving children. But I think it's important for people to understand the backdrop and the history. So hopefully that's helpful. What happens in research ethics is that risk has to be weighed against benefit, always. Risk is something that is always risk to the subject, really. I suppose a sponsor could have some risk of being sued or that sort of thing, but the person who's in research, really the risk is on them, and they can be harmed or wronged. There's an ethical distinction between those two things. Everybody know the name Henrietta Lacks, right? I understand they're building a building on the Hopkins campus up the street named after her. In my view, Henrietta Lacks was wronged, clearly. I'm not sure that she was harmed, though. So it's a good example, I think, of that ethical distinction. Risk involves both probability and magnitude, and when we're thinking about informed consent, we want to touch on things that are high magnitude, even if they're improbable, and certainly the common things. Benefits can be benefits to the child with cancer, but also benefits to society or other children with cancer, and benefit to the investigator for his or her career advancement, benefit to the sponsor financially. So that's a little of the balancing in research ethics. And I think sequence really matters a lot here, and I hope that those of you that are on IRBs remember that your job is to do a risk-benefit assessment before it ever gets to informed consent, because as I'll show you soon, informed consent is a deeply flawed process. It's never going to be perfect. It's never going to be able to really protect people from research risk or completely educate them about the study. So we need good IRBs and good investigators making that risk-benefit assessment in a thoughtful way before it gets to the point of consent. And the regulations have these features of ethical considerations in human subjects research. As I showed you before, they don't come out quite as clearly as Helsinki in saying that the interests of the subject should always be first and foremost, but they're pretty good, right? Safety has to be maximized, subject selection has to be equitable, informed consent is there. And then specifically for children, there are 4 categories. And without going into too much sort of regulatory geekness on you, I'm only going to tell you one category because I think it's the common one in childhood cancer most of the time. Subpart D of the regulation says that there are vulnerabilities. There's a subpart for prisoners. There's a subpart for pregnant women, which is its own interesting ethical question whether there should be. But for children, clearly there are rules and 4 categories of research that can be done on children. One is minimal risk. This is the second one, which has criteria I'll go over in a second. The third is greater than minimal risk, but only a minor increase over minimal risk with no prospect of benefit to the child. And then the fourth one requires approval by the Secretary of Health and Human Services to do. That's high risk with very little chance of benefit for the child. So most of our oncology studies, I think, go in under this 405 category. And it's a study that involves greater than minimal risk, but has the prospect of benefit to the child if the risk is justified by the anticipated benefit to the child, if the risk-benefit ratio is less than or equal to the alternatives, and if you have parental permission and assent. So that's the current state. We're going to go back in time now. Everybody put on your seatbelts and time travel helmets. And I'm going to go to a gentleman that I know Dr. Dome had the pleasure of working with. I don't know if others of you knew Dr. Dan Geo. Anybody else? Thank you. He passed away last year, and in preparing for this talk, I Googled him. I had assumed he had passed away actually longer ago. He lived a good long life, as you can see. He was born in May 1922. He departed this earth on September 14th, 2018. So that's 96-ish years of age. After a long, happy, and productive life devoted to family and the care of children with cancer. So that's the lead of his obituary. I also read a reflection that said, and I shared this at dinner, that the happiest moment of his career, the highlight of his career, was getting a note from a patient who had just given birth to her own child. Meant the world to him. He was an amazing guy. I can't say I knew him well, but you know, our field is incredible because we have these pioneers, some of whom are still around, who you can talk to and learn from. And I wanted to highlight Dr. Dan Geo because he was one of the first to understand that there was a cost of cure, that there were toxicities of the medications and radiation. He was a radiation therapist by training, and he really, I think, spearheaded the late effects movement in childhood cancer, which is a really, really important thing. But he had a history in the 1950s that I want to read about. Does everybody know who Sidney Farber was? Probably if there's a single name associated with the history of curing children with cancer, it was Dr. Farber. The Dana-Farber is named after him. He was a pathologist by training, which is interesting. A lot of the early folks in pediatric cancer were pathologists. And he studied aminopterin as an antifolate, and he discovered that he could get kids into remission, kids that had leukemia with aminopterin. And I'm going to, if you'll indulge me, read just a couple paragraphs from this wonderful book. You must read it if you haven't read it. Here I am promoting someone else's book. This is better read than the book. The Emperor of All Maladies by Sid Mukherjee. Many of you know it. Really, really interesting biography of cancer. So Farber is energized by the animal cures, quote. In 1955, he launched a series of trials to evaluate the efficacy of the drugs in humans. Actinomycin D, which had been studied as an antibiotic, was really effective at treating infections, unfortunately also really effective at killing healthy cells too. Wasn't going to work as an antibiotic. It had no effect on leukemias in children. Undeterred, Farber unleashed the drug on 275 children with a diverse range of cancers: lymphomas, kidney sarcomas, muscle sarcomas, neuroblastic tumors. The trial was a pharmacist's nightmare. Actinomycin D was so toxic that it had to be heavily diluted in saline. If even minute amounts leaked out of the veins, the skin around the leak would necrose and turn black. In children with small veins, the drug was often given through an IV line in the scalp. I don't know who's saying last night if you had to put in any scalp IVs, but I remember those days as a resident. They're not easy. So it was kind of a nightmare. The one form of cancer that responded in these early trials was Wilms tumor, a rare variant of kidney cancer. Often detected in very young children, Wilms tumor was typically treated by surgical removal of the affected kidney. God gave us 2 kidneys, so it's okay to take out one and you can still live, right? Surgical removal was followed by X-ray radiation to the affected kidney bed, but not all Wilms cases could be treated using local therapy. In a fraction of cases, by the time the tumor was detected, it had already metastasized, usually to the lungs. Recalcitrant to treatment there, Wilms tumors were usually bombarded with X-rays and assorted drugs, but with little hopes of a sustained response. Farber found that actinomycin D, administered intravenously, potently inhibited the growth of these lung mets, often producing remissions that lasted months. Intrigued, he pressed further. If X-rays and actinomycin D could both attack Wilms metastases independently, what if these agents could be combined? In 1958, he set a young radiologist couple named Dan Geo and Audrey Evans, and an oncologist named Don Pinkel to work on the project. Within months, the team had confirmed that X-rays and actinomycin D were remarkably synergistic, each multiplying the toxic effect of the other. Children with metastatic cancer treated with a combined regimen often responded briskly, and this is a quote from Dr. Dan Geo, in about 3 weeks, lungs previously riddled with Wilms tumor metastasis cleared completely. Imagine the excitement of those days when one could say for the first time with justifiable confidence, we can fix that. We can fix that. So I think about this a lot, and I wonder, as an ethicist, is it okay to judge what was happening then? Clearly, there was not informed consent. It didn't really exist much of a concept then at all. Children were desperately ill. The treatments that were available to doctors were very limited. And I think if OHRP were to come in and look at this, the Office of Human Research Protections, this would be a terrible infraction of all the rules that we have today. And I still think what they did was likely very admirable, and having known Dr. Dan Geo, likely there was an effort to communicate, but the regulatory framework just wasn't there, and every child with cancer essentially died if it couldn't be removed in that time. And I think we need to sort of appreciate that. And I think we also need to ask, what will they think of us now, 50 years from now, looking back? I think that's always an interesting ethical question to ask. We can get pretty self-righteous pretty quickly, especially these days, it feels like. And so knowing that history is important. Thank you for listening to that. I want to talk now about the phases of clinical research that really I don't think existed when Dr. Farber and Dan Geo and that crowd was doing the work. They were giving drugs without thinking about safety, followed by a look at efficacy in phase 2, followed by a bigger study looking at efficacy in phase 3, followed by post-marketing work in phase 4. And in phase 1 trials, this is from the NIH website, researchers test an experimental drug or treatment in a small group of people for the first time to evaluate its safety, determine a safe dose range, and identify side effects. What's missing from this definition? Really nothing about efficacy. The goals of our traditional phase 1 design has nothing to do with efficacy. Phase 2, some safety still, but some efficacy. And phase 3, a very large study to look for efficacy and compare to our best known standard treatment or to a placebo if there is no known standard treatment. Although in childhood cancer, placebos are not used very often. So as some of you know, and as Ann mentioned, I had a 15-year career as a researcher with 3 5-year grants from the NIH, looking at questions of informed consent in childhood cancer. And the main animating question really was something that I heard when I was in training in the mid-'80s. I heard people say, research is the standard of care for children with cancer. So I was trained in ethics, and I thought, wait a minute, I thought research was optional. And yet I was trained in oncology, and I had mentors saying, go get that kid on the study. You know, research is the standard of care. And that led me to write a grant, which was not funded the first time. So those of you that are in the early phases of your career writing grants, don't be despondent if your first proposal isn't funded. But I wanted to improve informed consent when children were diagnosed with leukemia. And the peer reviewers in their wisdom said, you don't know what's happening now. Revise your grant, figure out what's happening now, and then come back to us with a proposal to improve the quality of consent. So that's exactly what we did. I was interested in whether parents understood randomization. Later on, we got to phase 1 trials, which are ethically interesting. And you can read the questions here for yourself. But I want to spend a few minutes talking about 2 of the 3 projects. The first is Dr. Angiolillo referred to was a study that was done in part here and at 4 other sites around the country, where in 140 cases, when a child was newly diagnosed with acute leukemia, we got consent to study consent. We decided that the only way to find out what was happening, and these were audio tapes that started in 1999, so it was pretty low tech. And anyone who was diagnosed with leukemia, AML or ALL, and was going to be offered a phase 1 study, we had a research assistant at the site who would get permission from the parents to tape the conversation, and we had permission from the physicians too. And in this 140 sample, 85 of the parents said yes to the randomized clinical trial. This is how we did it. You can see here that this is sort of where we got consent to study consent. We did focus groups and a parent advisory group afterwards to learn from parents. And I'm going to go through it pretty quickly, only to say that you'll see Dr. Angiolillo here as one of the co-authors. This paper from JAMA in 2004, I think was a game changer, I hope, in pediatric oncology, because it showed that in 83% of cases, the randomization was explained. We had it on tape. 95% of cases, we knew parents got a consent document explaining randomization. But 50% of parents, half parents, did not understand randomization, despite the fact that 85% of them had said yes to the study. Having a nurse present during the consent conference was associated with better understanding. Very interesting finding. And parents who were minority and lower SES status were less likely to understand randomization. We also found that although 89% of investigators tried to explain to parents that they had a choice, only 2/3 of parents understood that they had a choice. A third of the parents felt that they had to, this was the treatment being randomized. So those findings, I think, were important and led to a second study to try to improve the quality of informed consent that I don't have time to go into today. But I think there are still gaps. I think we're getting better probably as a field, and people are studying this more, which I think is very gratifying. But we need to continue to do better with our consent process. And then we moved to phase 1 studies where there's this incredibly difficult decision that parents and families have to face. Are they going to use non-conventional approaches? Are they going to do hospice or palliative care? Or are they going to try an experimental drug? And what happens during the consent process for phase 1 studies? We used a very similar methodology. We know that 1/3 of children who die of cancer in the U.S. participate in a phase 1 study during their illness. So this is a common thing. And we thought studying the communication would be helpful. We had 85 consent cases here, and we interviewed 60 parents afterwards. There was a decision to say yes to the phase 1 study in 81 of the 85 cases. And in the 4 cases that the child did not go on the phase 1, they were found to be ineligible in 2, probably ineligible in 1. And there was really 1 out of the 85 where the family said, you know, no thanks. So that surprised us a little bit. We measured parental understanding concepts in this way. And pardon me for going through it quickly, but I want to, again, have time for discussion at the end. We measured parental understanding for each of these 3 key concepts on a 0, 0.5, or 0.1. So the highest score a parent could get for understanding was a 3. And here are the understanding scores. The three concepts are drug safety, that the study is looking at safety of the drug. The second is dose finding, the idea that there's an escalation of doses. And the third is escalation of doses. And then there's a composite, understanding the scientific purpose. And like many things in life, it was about a third, and a third, right? A third of the parents had decent understanding, a third were in the middle, but a decent number of parents really had no understanding of the scientific goal of the phase 1 study. And only 5 of the 60 had sort of perfect understanding in our view. Again, there's areas to improve here, and there are also areas where you can see this graph from the paper was in the Journal of Clinical Oncology. These blues are how much the doctor explained of these three concepts, and the orange dots are what parents understood. So these are all cases where parent understanding was a little bit less than what the doctor explained. These are all cases where the parents actually had read through the internet or however they learned about it, and on tape at least we didn't have the doctor doing any explanation of it. So we also need to remember when we're doing informed consent that there are multiple avenues for getting information that parents have. And our, how shall I say this, deliverable or enduring material from this was a cover sheet, again, working with a parent advisory group of parents whose kids had been on phase 1 studies and the children had passed away, but we were really grateful to these 8 parents for coming to teach us how to interpret this data. And they said, this is sort of the purpose of a phase 1 trial. We should say there is a chance of toxic side effects. It's unlikely the treatment will cure your child. Benefits could include symptom reduction, the opportunity to help others in the future, emphasizing the voluntariness and the fact that you can get out at any time, and then some basic definitions of the things we were looking for, including palliative care, and quite possible to have concomitant palliative care and phase 1 participation, at least in pediatrics. And adults, I think it's more difficult. So that was the take home from that. The NIH on their website has adopted our approach to improving consent in clinical trials, which is very gratifying, and again says that hopefully they made a good investment by funding this work. Kind of a checklist approach to how to do informed consent in this section for healthcare providers. We have about 10 minutes left, and I'm going to conclude and then open it up for discussion if that's okay. Balance is real important in ethics, and I think when we think about research with children, the best interest of the child subject has to be balanced against science to benefit others. And when push comes to shove, I've already sort of spilled my agenda, which is the best interest of the child subject has to take precedence. In ethics, we say people shouldn't be used as a means to an end, and we certainly don't want to use a child who's sick as a means to an end. But we also want to strive to cure childhood disease and alleviate the suffering of children as a class. I think most people agree that children have been understudied and overprotected. So how do we reconcile that tension? I think they're both ethically important. I think that risk-benefit assessment is more important than informed consent. As I said, that's a fallible sort of thing. And I think the regulatory fervor sometimes it's intended to protect children from research risk can threaten what can be a very ethical conduct of pediatric research. So a lot of people, I think, read our phase 1 stuff and said, oh, that's terrible. Isn't phase 1 research in children unethical? And I say no. We need to do a better job with informed consent, but there's nothing at all unethical about having young children, older children who can participate, be involved in phase 1 cancer studies. And the landscape is changing already as we have more molecular drugs, and our old sort of pairing of toxicity and efficacy isn't necessarily going to be what it was before. So we need new ways to think about first-in-human studies that aren't sort of that traditional phase 1 design. I've said this already. I think both and is true. So what are our responsibilities as the pediatric oncology community? I think we have to design trials that answer important questions. We have to power the studies so the answers will be as definitive as they can possibly be. We need to assure that new agents are available after the completion of the study if it's a positive result. And that's a shared responsibility with the sponsors. This market approach to drug development is a reality. So we need to be smart about how we're going to work with industry to get drugs to children. And that's not easy. One of the enduring themes, I think, in pediatric ethics is who gets to decide. As a child gets older, that gets more and more difficult. I think there are hard questions about how seriously we take dissent, at what age, at what point in the disease trajectory. A child who's newly diagnosed is very different than someone who's been through treatment, which cultures, lots of other questions in the enduring themes. I've already, I think, made the point that dose escalation studies are very different than randomization as a scientific concept to try to convey during informed consent. In phase 2 studies raise safety and efficacy considerations. I think this idea of novel study designs is going to require a different way of thinking about the ethics of pediatric cancer. And in terms of the informed consent work we've done, and I think other great investigators are continuing to do, understanding both disclosure and how much parents and older kids understand is critical. So with that, I will thank you for your attention. Looking forward to your comments and discussion. Criticism, too. If I said something that you disagree with, please. Again, I think for our students and trainees, we need to model this idea of respectful disagreement. So please, Dr. Rubin. Yeah.
I was wondering if you now some of our favorite how do we deal with that? Make information more understandable. So much that we I can't stay for the response. You have to go run an IRB.
You can use this cover page as you walk out. I'm happy to email it to you if you don't have it. But the idea here was an acknowledgement that a one-page cover page, so a doctor can in good conscience say, or an investigator to a family, here's 30 pages, you're welcome to read it, but a lot of this is regulatory, jibber jabber. And when you buy a house, there's a lot of stuff you probably don't read. Families have had experience with that. If you want to read it, I certainly support it. But here's a one-page summary that gets at it. And for phase 1 studies, I think this is one example of that. The second part of the answer has to do with the use of technology and web-based and interactive forms of informed consent videos. I don't know if people have seen these sort of stick figure animations that are done. There's all sorts of new ways, and figuring out that different people learn different ways and trying to match the type of learner the person who's doing informed consent is with the way they would learn best would be another way to think about it. Yeah. I'm not sure. It sounds familiar, but what did I say? Yeah. Yeah. Sure. Yeah. No, I think it gets back to the head and the heart, and we aren't very comfortable with silence. Sometimes communication training is being done more and more in medical school. But it doesn't get done often enough in a pediatric oncology training where you have a very specific context to do it. So, one should be at the same level of the patient and family, hopefully sitting down, handing your beeper to somebody else who's outside of the room, being truly present for a family, whether it's at the day one talk. There's a wonderful paper by Holcomb Greer about how to do the day one talk. And how do you integrate that with an ask to be in research, I think the key there is to separate it out, and that's what we did in the second study that I didn't talk about. The model that we employed was on the first day talk about what the disease is, and then have, if the family is doing okay, talk about what treatment looks like on the first day. But if the family is overwhelmed, as many of them will be, say, you know, I'll come back later today, or I'll be back first thing tomorrow morning. So reading your families and your patients is really the key. Just like going back to the very first, the story of Abby, you know, how would I respond to her? I would try to read her. You know, I would try to say, what does she need from me in this moment? For newly diagnosed leukemia patients and families, what is the disease? What is treatment? And then I think you need to tell them something about treatment in that first meeting, but it doesn't have to be the randomized clinical trial. If they're doing okay, you can introduce the randomized clinical trial, maybe, but better to do that in a second visit. And at the end, get back to the fact that it's their decision to make. And I think what parents need to hear most is that you're going to take really good care of their child, whether they're in the study or not in the study. And thinking back to the 1980s, you know, when I was in training and I had mentors saying, go get that patient on the study, it was hard in good conscience to not feel disappointed if the family said no to the study. And really the message is the most god-awful thing in history has just happened. Your child has been diagnosed with cancer. I'm here to care for your child. So is it a mixed message in some sense to get consent for research, and how can we mitigate that mixed message while still doing important research?
Thanks, Eric. That was really great and very important work. I have a research methodology question. Mm-hmm. So with this type of research, you record how much does the actual recording influence the discussion?
Yeah. 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 Thank you for that. So Dr. Dome is referring to something research methodology geeks call the Hawthorne effect, where the act of studying something influences the study in itself. We trained our research associates to. It was a tape recorder that was about this big in the first study, and we asked them to place it in an Anne remembers this, unobtrusive place, and to sort of sit in the corner of the room and take notes. And we feel, best we can tell, that they did a good job with that, and that the Hawthorne effect wasn't a very big impact. Also, as we talked with parents afterwards in the parent advisory group, they said, you know, we were so blown away by the fact that our child had just been diagnosed, we weren't paying any attention to anything other than the doctor. So we think we got a pretty accurate read, but you're absolutely right. If there was a Hawthorne effect, then maybe 30% of parents would have understood randomization instead of 50%.